It's great to have the experts in technology to have a wonderful discussion and take home messages on a topic that is one of the most talked of topic in technology and diabetes today. That is time in range, what methods we use, how do we translate what we call as normal, what will get translated into its association with the complications. So I'm sure we have exciting subtopics under this, and one of the most sort of speakers who can talk about technology. I welcome all of you, Manoj Chawla sir, Jyoti Dev sir, Dr. Mangesh Devaskar sir, and Dr. Amit Gupta. I'll hand over the mic to Dr. Manoj Chawla, who we all know as a director and consultant diabetologist at Alina Diabetes Care, Mumbai. A very passionate clinician, have been working in diabetes for so long. Many credentials to his cap, and I would request him to take over the session. First, introduce our expert speakers, and then start the discussion. Over to you, Manoj sir.
Thank you, Anjali, and thank you, Neeta and Sanjay and the whole team of Hbanc for inviting me for the conference. I'm hearing a lot of echo. Is it me or everybody's hearing that echo?
I am also getting the echo.
Yeah, great, thanks. Okay, so thanks for inviting me, and I believe the only reason I've been asked to be the lead for this EBM is that I have more gray hair than Jyoti and Mangesh and of course Amit. So that I see that as the only reason that I'm here amongst the experts in technology in India. And thank you organizers for also sending me this coat to wear. I was told that Dr. Jyoti always wears one, so I should also wear it. So Neeta, thanks for the coat which came in. Let me introduce the panelists for this session that we have on time in range. I begin with Dr. Mangesh Devaskar, who will be joining us on this soon. Well, Mangesh has had an extremely illustrative career, I must say. Gold medalist for his MD Medicine. He's the Honorary General Secretary for National API. He's the elect editor-in-chief. This February 2022, he takes over as the chief editor for JAPI, and we'll be all reaching out to him for various articles. A lot of publications to his credit, and he's the MRCP examiner as well for the Royal College of Physicians, UK. Can I have the next slide? Dr. Amit Gupta is the Director for Center for Diabetes Care at Greater Noida. He's an advisory board member for American Diabetes Association and an extremely influential member with ADA and ACE, taking recommendations from the Indian physicians for the kind of programs that you want to see, and as part of the subcommittees there. He is part of the RSSDI National Social Media Committee member and extremely active again in the entire drive for Defeat Diabetes and the social media platform as well. He is an Apex body member for the Art of Living, and we see his visits with Shri Shri, and he's been instrumental in including Shri Shri in the launch of the new app for RSSDI Defeat Diabetes, and he's an endocrine practice reviewer and other credentials to his credit. May I have the next CV slide? Extremely difficult and humbling for me to introduce Dr. Jyoti Dev, whom I consider the actual technology man and who's been an inspiration for many of us trying to do some bits of work in the technology area. Dr. Jyoti runs his diabetes centers at a couple of places in Kerala, his main center being in Trivandrum. He is the chairman of Jyoti Dev's Diabetes Research Center at Trivandrum, Kochi and Attingal, managing trustee for the Kesav Dev Trust, which does a lot of work in terms of education and charity and literary activities. He's the editor-in-chief for International Journal of Diabetes and Technology, extremely active in talking about technology, in conducting and being at the forefront for trying out new technologies and enlightening us as well. So great pleasure to have all the three speakers today in this EBM masterclass. Took me a while to understand what EBM meant, and then of course I realized that we're talking about evidence-based medicine, and sometimes you start thinking very deep as to what this could be. I was trying to think in EBM, I don't find a Sanjay initial, I don't find Neeta or Anjali, so what does this EBM stand for? But then it made sense as to what we're talking about. So yes, Mangesh, I can see Mangesh finally, and Mangesh is busy at his clinic, but will be sparing time to speak to us. Over the next 45 minutes, we will have 4 short talks. divided amongst various aspects of time in range, and then throw it open for questions from all of you. So we invite questions from all the participants who are joining us. Let me start by sharing my screen. We're going to be covering different aspects in this masterclass about time in range, methods, evidence, interpretation, and indications. The time for each expert is about 7 to 8 minutes, and hope and request that all of us, including myself, stick to the time. I'm going to be talking about the concept of time in range, some of the limitations of Hba1c, the glycemic variability, its implications, and the practical implications or applications of time in range. Now, standardizing CGM metrics and reporting. So this has been the journey for CGMs being introduced and approved in the US in the early 2000s to first proposal of standardizing a CGM report. And we know that before that, there was just too much of data. And as it is said now, that a lot of data can actually be a cluster, and a cluster would mean lack of clarity. So it was good that there was some standardization in the form of AGB proposed by Maze, Bergenstahl, and others in 2012. And then in 2013 to 17 was the gradual introduction of CGM metrics, including time in range. 2019 saw an international consensus on CGM TIR targets. And Jan 2020, which was last year, you see the ADA including CGM in 2020 standards of diabetes care, and 2021 has gone a step ahead, and I'll be coming to that. So what exactly is time in range? Time in range refers to the time spent in an individual's target glucose range, which is usually 70 to 180. For some, it would be 70 to 140, and some even 63 to 140, especially in pregnancy and diabetes. It is the percentage of time also which is spent below range or time spent above range, and there will be a lot of light thrown on this aspect in talks ahead. Time in range may be used as an appropriate endpoint in clinical research and as a measure of glycemic control in patients with diabetes. And there is strong emerging evidence that TIR is inversely correlated to the development of both micro and macrovascular complications in diabetes. Now we talk about the limitations between Hba1c and TIR, and we need to understand this, that Hba1c, it evaluates a single Hba1c value ideally at every 2 to 3 months, compares 3 months, does not capture hypoglycemia or hyperglycemia, so doesn't tell you much about glycemic variability. Any immediate effect of therapy changes cannot be understood or recorded. It has bad correlation to patient-reported outcomes, high susceptibility to interference with anemias, hemoglobinopathies, laboratory issues, and so on. And the favor for Hba1c, or the point in its support, is still extremely good correlation to clinical endpoints and long-term studies. So the hardest endpoint today that we have of link between poor control and complications is still with Hba1c. TIR, on the other hand, evaluates continuous glucose levels, compares different time periods, captures all the glucose values, immediately detects any acute effects of therapy, whether it's going into hypoglycemia or reduction of hyperglycemia. Good correlation to PROs, low susceptibility to interference from any of the aspects mentioned earlier, and correlation to endpoints is still unclear and emerging evidence, so not yet substantiated. So you can have similar Hba1c but different glucose variability. These are amongst the classic slides that we always show as to why the need to move beyond Hba1c, because your patients with same Hba1c can have completely different glycemic patterns and variability, and hence the need to look more closely to the movement through the day. There is correlation between Hba1c and TIR. There are a couple of models postulated. The most accepted one is the Vygotsky calculation, which tells us that why a particular or what a particular Hba1c will denote in terms of time in range. So if you look at 70% time in range, it would mean an Hba1c of 6.7 in percentage, and that's what we understand. The simple further understanding is for absolute 10% change in TIR, there would be a 0.8% reduction in Hba1c. There is a strong link with complications of time in range, which is emerging, and Dr. Jyoti Dev would be speaking about with the link with complications. How do we really measure TIR? So CGM is the ideal tool to measure TIR. SMBG can be used, but if you don't have sufficient data points or points in range, you will not get the accurate TIR. So more than 5 times per day is required. The more, the better. If you're using SMBG to calculate TIR, there's a simple formula. you will have values in the target area. So if your target for the patient is 70 to 180, you will have those values in the target area divided by the number of values into 100 to get your percentage reading. For example, if you've done 7 readings in a day and you have 5 in the target range, that's 5 by 7 into 100, you'll get 70% as your time in range based on SMBG. Not as accurate, but in limited resources, you can start using this as well. Now, this is time in range through CGM. I'm showing this because this is one of the newest CGMs called Glunovo real time, which we are currently evaluating. And this is a recent data for a patient who's using this, which not only tells us the real time glucose value, but is also showing the time in range. And you can clearly appreciate here that no time below range, about 66% time in range and about 34% still above range. This individual where we're trying out the Glunovo real-time CGM. There has been evolution of glycemic target. So the 2021 AD, and this is what I was talking about earlier, talks about glycemic control being best evaluated by a combination of A1C and time in range. So we talk about moving beyond Hba1c, but not discarding Hba1c. So everybody, when there is a debate in conferences like this, A1C versus TIR, well, it's kind of rubbish because you need both these metrics today. You need Hba1c, but you also need TIR to further substantiate and look at the glycemic stability. Time in ranges are going to be time above range and time below range. Everything's important. And Dr. Mangesh will be speaking much more about all the recommendations and describing in further the levels of time above and below range. Why are they important? Because both these aspects are going to have consequences. You have low sugars, there is going to be hypoglycemia unawareness, increased mortality risk, cardiac arrhythmias, and a lot of undetected hypo. You have high sugars, and it's going to cause increased risk of ketoacidosis and complications. Now, this is one aspect of really understanding and picking up the time above range. So when you start doing CGMs and start looking at the data, we need to understand that every 5% increase in time in range is going to be clinically beneficial. 1% is approximately equal to 15 minutes and 5% is 75 minutes. So if you are able to increase your patient's time in range by 75 minutes in a 24-hour period, that is going to have clinical benefits, and that's important for us to note. Now, this has been some of our work in papers, the CGM recommendations that we came out with the blessings of various experts here, which spoke about the need for more regular CGM in our practice. This is the consensus statement on AGP led by Dr. A.G. Unnikrishnan, and again, many of my colleagues who are either organizing this conference or part of this masterclass being co-authors for this consensus. And then we had 2 papers which were presented at ATTD last year. This was insights to the time in range. And this was a multi-centric. We saw data from our centers at Lina Diabetes, Purvi and myself, Dr. Bansi's, Dr. Jyoti's and team. And we saw that the average time in range, even at these centers, was somewhere closer to 60%. We wanted to look and see that how you have an average Hba1c in India, whether you can have an average time in range that the patients are achieving. This was the initial effort. And we look forward to collaborating with many centers across India to try and understand an average time in range for Indian subjects. This is again an important aspect that when we talk about adoption of time in range and technology, there is a gender bias. We still are not seeing a lot of work being done in the female gender. Again, collaborative work with Dr. Archana and many of the experts with Purvi. And this paper was again accepted and presented at the ATTD. Now, quickly, I'm going to talk about some practical applications of TIR in clinical decision making. This is clinical utility of Hba1c, which is enhanced when used as a complement to time in range. So when you talk about Hba1c, you can see here patients with the same Hba1c, but when you do their CGMs and you look at their AGPs and you look at the time in target, these 2 patients with the same Hba1c, this one has 46% in target, this one has 64%. So clearly depicting that only Hba1c is not sufficing. You want to start looking at their time in range metrics. This is again time below target, picking up hypoglycemia trends in different Hba1c subgroups. We are talking about different A1Cs, somewhere close to 5.5 or 6.3. You expect some hypoglycemia. So you are seeing 18% time below target and 11% time below target. But here, this is somebody with an A1C closer to 10%. Of course, estimated A1C does not mean actual Hba1c, but these patients from our profile had A1Cs closer to the numbers we are seeing. And here also you see a time below target spend 10%. Somebody who has an HbA1c of 9 or 10, if we think that they are not spending below range, that's mistaken. The other clinical utility is using this tool to understand impact of lifestyle and medications. This is purely lifestyle. We had an individual who chose to stick onto lifestyle and worked onto it, and we did 3 serial CGMs over regular intervals. And we see the time in target here improving from 41% to 65 to eventually 74%, extremely satisfying for the patient to understand and move ahead. Finally, impact of medication in drug-naive patients. Some patients would be afraid or want to see how they are responding. So this is, you're doing a CGM here, and you are evaluating the time in range. From day one, when the patient has started therapy, when the time in range is only 4%, eventually till the end of the AGP or CGM period, you are again seeing the time in range improve to 82%. Extremely satisfying for the patient looking at that time in range improving. So treating type 2 diabetes, friends, is without data is like flying blind, and we need to see where we are going. The world is changing. Hba1c is moving towards time in range, and I said earlier that this has to be complementary to each other. Different countries are adapting this. I'm extremely glad that India and physicians in India are adapting this much earlier than a lot of countries in the world. Everyone's been talking about time in range, and that's what we are going to be taking ahead in today's session. The take home for all from my presentation, and we'll of course discuss at the end of all talks, is that this clinical tool is simplifying life for our patients, increases patient understanding about their diabetes, increases patients' onus about self-care, helps reduce Hba1c and better manage diabetes, helps people with diabetes reduce long-term complications, and helps us reach a more targeted treatment option. To understand this better and see this more in clarity, may I now invite the rest of the experts for their presentation. We are starting with Dr. Jyoti. Is that right, Jyoti?
Yes.
Yeah, please.
Am I visible?
Yes.
Okay. So first of all, thanks to my dear friends, Dr. Manoj, Dr. Mangesh, and Amit. And thank you very much, Dr. Nida, Dr. Sanjay, and the group, IDEC, for inviting me. And hello to Anjali. So this is going to be a continuation of what Dr. Manoj has said. So I will be spending another 7 minutes. Manoj, I got a red one. So I am going to discuss on the methods and the evidences. So Dr. Manoj and we have decided that we will split the topics amongst us, and I'll be focusing on the methodologies. So Dr. Manoj has discussed about TIR in detail and a brief introduction on the CGM devices. So what are all the devices which are available with us for assessing the continuous glucose monitoring? Because you need 14 days of continuous glucose monitoring, of which 70% of the data is available for a meaningful evaluation of time in range. And the time in range can be for 7 days, for 14 days, and even beyond that. So these are some of the devices. I'll be, of course, making a brief demonstration of some of these devices. But how do you classify it? So the broad classification of continuous glucose monitoring devices will be, number one, the real-time devices. The real-time devices are those devices which will display the values in real time all the time. So one example is the Guardian Connect, the sensor, which is very popular, which can be applied over the abdomen, or even nowadays it can be applied over the upper arm as well, the generation 3 sensor. And then the example of an IS-CGM is a flash glucose monitoring device, that is the intermittently scanned CGM. And then you have the blinded CGM, and in the blinded CGM, you will download the data at the end of recording, and that can be at the end of 7 days or at the end of 14 days for Libre Pro. So Pro stands for the provisional version. iCGM is currently not available in India, and these are examples of CGMs which can integrate with a third-party device. It can be a connected insulin pen, it can be a connected insulin pump, or it can be a third-party dosing algorithm which is integrated in the smartphone. So very recently at the American Diabetes Association, we presented this data. So Dr. Manoj just presented the data on the correlation between A1C and the time in range. So a time in range of around 70% correlates with an A1C of 7%, which is the data which has accumulated from the studies which has been conducted by Vygotsky, McMahon, And these were in Caucasian population. So we tested in our population, and we also found that it is closely correlating in our population, and exactly what Dr. Manoj said, aligning to his observations and the recommendations. TIR and Hba1c are different. If you look at this chronic care model from our telemedicine, Hba1c less than 7.5% is achieved by 67.5% of the patients. And this is the data. But if you dissect and if you look at the TIR data, it is quite different. Those TIR more than 70%, that is achieved by only 36% of the subjects. So these two are completely different. So even when the Hba1c is the same, the TIR is going to be entirely different. And more the TIR, if the TIR is different, and if it's more of glucose variability, these are the patients who will come and complain to you that, doctor, I'm having mood swings. Doctor, I'm having tiredness all the time. And I feel exhausted all the time. And the TIR, what is the significance in clinical practice? This is the DCCT derived data. If the TIR is less by 10%, assuming that the TIR is 60% and not 70, or from 80 to 70%, 10% lowering of TIR increases the chances of retinopathy by 64 and microalbuminuria by 40%. Neuropathy increases by 25%, and there are evidences to show the increase in surrogate markers of macrovascular complications such as carotid intima media thickness, again related to TIR. So these are some of the devices. Let me stop sharing now, and I will spend a couple of seconds here to demonstrate. So this is the Texcom Reader. Of course, it is not available in India, but Texcom is supposed to be one of the best devices. And this is supposed to be the gold standard with the lowest MARD and the highest accuracy. And this is, of course, the sensor from Medtronic, which connects to the Medtronic devices, the Guardian Connect, and the Guardian Connect connects to your iPhone or any compatible other phones.
One sec, Jyoti. Can I ask the organizers to pin on Jyoti, because he's going to demonstrate, so we have him on the screen. Can the IT guys just pin Jyoti's video currently?
Yeah, to spotlight. Thank you very much. Thank you very much, Dr. Manoj. So Manoj has asked me for a demonstration. So I will show these once again. So this is the Texcom sensor, and this is the Texcom transmitter, not available in India. We are just demonstrating this from our clinical research department. And this is the Texcom, which is a monitor. Of course, we can also use a smartphone. And you have two sensors for Libre, the Freestyle Libre Pro and the Freestyle Libre. The Libre Pro comes with a reader which is white in color, and this is there with your office all the time because it is a professional device. Whereas for the Libre, it comes with a reader which is black in color. And let me have a demonstration, because I have put a sensor over here for the demonstration, and it takes only a couple of seconds. I will say that microseconds to have this flash glucose monitoring. So this is an example of intermittently scanned device. So every other minute I can scan. See, I am scanning over my clothing, and this is my glucose value 124. So these are the popularly available devices currently in our country: GC, Libre Pro, and Libre. And this is a publication from Dr. Mangesh Devaskar. So all of us are involved in generating evidence from our own country. And this is a reality in India. And this is from our own Dr. Manoj Chawla, his consensus and recommendations on the use of CGM. And this is Guardian Connect in the beginning. And this is 25% time in range. And in the end of 3 weeks, it is 100% time in range. So this is the beauty which Dr. Manoj has already described on how you can gather the data, interpret it, and translate into therapeutic decision-making and better outcomes in diabetes. And this is how you can scan, and the reader can also display the data on time in target, below target, above target, and the arrows in the reader or in the Guardian Connect that indicates the magnitude and the direction of change of glucose. So the arrow is pointing upwards vertically, then the glucose is rising very quickly. If it is slanting, then the glucose might be increasing only by 30 milligrams in the next 30 minutes. And this is sharing a glad news and exciting news with you. Maybe for the first time in the history of AS, American Association of Clinical Endocrinologists, in their 2021 practice recommendations in technology, they have incorporated an original research from India on continuous glucose monitoring. And we have been using the virtual COVID IP care. We are still very active with our VCIP because COVID is still a nightmare in our state in Kerala, with a lot of patients even dying every day. And this is how we are doing interventions, including corticosteroids and injectables at home with remote monitoring. And in this new interventional home care model with more than 99.95% success, we have shown that it is possible to keep more than 95% time in target, more than 95% time in target with less than 1%, that is less than 15 minutes time below 70 milligrams per deciliter. So this is an urgent need. This is Dr. Benji Sabu and the group. To implement time in range as a target is an urgent need all over the world. And this is exactly what we are discussing today. Thank you very much, Dr. Manoj and Ti.
Thank you, Jyoti, for taking us through all the newer papers, the evidence for the same, the link with complications, and we will continue to discuss and take questions from the audience. So we now move to the presentation by Dr. Mangesh, and Mangesh will be speaking to us about the different recommendations and explaining in detail what really aspects of the time in range, above range, and below range mean. Mangesh.
Thank you very much, Manoj. Thank you, Dr. Jyoti, Dr. Amit, and entire team IDEC, Neeta and Anjali and everybody. And Manoj, you really spoke beautifully as far as the context setting, and most importantly, you really set the ball rolling as far as how important to understand the importance and the value. And if you remember the poster that you presented in last year's ATTD, it was last year's ATTD 20, probably it was ATTD 2010, was it? Where for the first time the concept of time in range was discussed, right? It was that time, and now see, almost a decade down, now even the guidelines have started speaking about it. So this is how the whole I would say the concept of time in range and the importance of glycemic variability has changed. Okay, so that is very important for you to understand. And as we progress, as we have appreciated Neeta's efforts and the team IDEC's efforts to appreciate our all Olympic gold winners, let us also put our hands together for Paralympic gold and the medal winners. And till yesterday evening, probably the tally was 13, 2 golds, 5 silvers, and 6 bronzes. So that is how our Paralympic champions also doing well. So let us appreciate them as well. So talking about time in range, what are the recommendations, as Dr. Jyoti and Dr. Manoj has beautifully, setting the context. This is what Dr. Jyoti was talking about, how important it is that more the time you spend outside the range, the likelihood of both micro as well as macrovascular complications are very high, but especially microvascular complications, which are very difficult to treat, are one of the most challenging areas which can be effectively addressed by just monitoring the patient's time spent into the range. So this, Manoj, has already shown you what exactly you mean time in range, but how much time and how do you classify various ranges? See, we need to understand the regular range for most of the diabetic people is between 70 to 180. In few of the occasions, it can be up to 70 to 140. In diabetes in pregnancy, especially when it is type 1 diabetes, the range can be still tighter, and the time in range needed to be spent inside the range also goes up significantly. So let us look at various ranges. If you really see, this is the green, which we are seeing on the screen, is the time which is required to be spent in range, that is in between 70 to 180. And majority of the times, the patient is expected to spend more than 17 hours in this range to have the minimization or the reduction in the target organ damages. Now, if the range is, in the range of 181 to 250, then that is called as level 1 of hyperglycemia. And here, probably the patient is allowed to spend not more than 15%. And even lesser percent of the patients are allowed to spend in the level 2 hyperglycemia, which is usually about 50 milligrams. And remember that this range between 250 and above should be as low as possible. Similarly, if you really look at time below the range of 54 to 69 is called as level 1 hypoglycemia. and lower than that it's called as level 2 hyperglycemia, and at no point patient should be spending less than 4% or less than an hour's time in the time below the range. So these are various different I would say recommendations for the time in range for different diabetes populations. You can clearly see that garden variety type 1 and type 2 diabetic patients, this is what we exactly have discussed, that the patients are expected to spend more than 70% time in range, and then the time above range should be less than overall 30%, but the higher or the level 2 hyperglycemia should be less than 5%. And this is what we talked about, the time below range is that less than 4%. Now look at this older population, high risk population, type 1 diabetic with the high risk population, probably the time to be spent in range is little liberal, people are little liberal, and there you can have your patients to spend around 50% of the time in range, and then you may have 50% or lesser time spent above the range, but at no point you should be allowing them to stay below the range as much as possible. As Dr. Manoj has already spoken to you, look at this, if it is type 1 pregnancy, then you need to spend a lot of time in the tightly controlled time in the range of 63 to 140, and you are supposed to spend more than 70%, either the lady has to spend that much of time in the range to avoid complications related to pregnancy. But if it is type 2 pregnancy or a gestational diabetes, then almost nearly the range is same, but the thing is this, that the majority of the time the patient has to spend the time inside the range. But then probably Dr. Sanjay Kalra and team thought that we need little better clarification on this. We need little more, I would say, diversification of the recommendation. And that's the reason why an expert group of 15 countries, including India, which included Nepal, Indonesia, Ghana, and some of the African countries, and they came out with the similar concept, but then they came out with a very, very specific population-based guidelines. Like look at this, adolescents, probably the same time in range, 80% or more for type 1 diabetic patients, garden variety, and 70% or more of type 2 diabetes patient, garden variety, to be spent in the range. Time above the range, same 15% for type 1 diabetic and 25% for type 2 diabetic, and time below the range at no point of time should cross 5%. Adults with type 2 diabetes is and fairly well controlled people, the time in range roughly stays same. Pregnancy, same, we have not to go ahead. But then elderlies, you need to look at this. The range have changed itself from 170 or 180 to 200. Now this is what is the difference. And here also the elderlies, those who are not having any comorbidities or they are having a normal life expectancies, then probably they should be treated as the regular adult patients, and the time in range criteria should be the similar application as for the any other people. People those with high risk of hypoglycemia, having renal and hepatic disease as well, should be also spending time in range for more than 70%, but little still better monitoring. But then what is most important is the microvascular complications and the macrovascular complications. For all these populations, the time in range needs to be very tightly controlled, and at no point of time they should be allowed to go below the range by more than 5%, that is for sure. People with concomitant infections and comorbidities, the time in range stays same. I think this is for my part of the story. Early over to you, Manoj, for the further talk.
Thanks, Mangesh. I think that's extremely important today, that when we're talking about time in range, for everybody to understand what these numbers are. Just the way today we can rattle out the blood sugars and Hba1c numbers and explain to the patient, these numbers are important, especially when we're trying to explain to the patients and passing the control and the onus of control back in the patient's hands. So those numbers were extremely important. We'll of course discuss the other guidelines which you showed for adolescents and adults, and that Asian paper from Sanjay and others that you showed. We'll discuss that in the chat session. Now we move to final presentation here by Dr. Amit Gupta, who's going to be talking about an important aspect. Now that we all understand that time in range is complementary to Hba1c, how do we really improve the patient's time in range, reduce the time above range, and minimize or avoid any time below range? So over to you, Amit.
Thank you, Manoj sir, for giving me this opportunity. At the outset, I would like to thank Dr. Neeta and Dr. Sanjay sir for giving me this opportunity to be to present at this very, very prestigious forum. Sir, as you have rightly said, we have already discussed, you have elaborated well in detail that what is time in range, and it is not the same as the HbA1c. And secondly, you also told us that what are the targets, and Dr. Jyoti Dev sir has already demonstrated various devices that how do we calculate time in range. So now for the next 5 to 6 minutes, I will be speaking. Is there anything which we can do to improve time in range? So this is a very, very important thing. And I would like to highlight upon the strategies which can be there. My full screen is not visible, sir.
Not yet, Amit. We'll have to make it full screen.
Just give me a second, sir. I hope it is visible now, sir. So I would just like to highlight that there are intraday as well as the interday glycemic variability, and we have seen that these are the risk factors in people with diabetes. And now there are several factors which have been proposed to help reduce glycemic variability and improve TIR. And one of the strategy is to change the TIR is the insulin treatment. And the factors which contribute to improving glycemic variability and TIR are timely insulinization, choice of insulin, initiation of the right dose, proper timing of the injection of the prandial insulin, systemic and the adequate titration, and the prompt intensification when indicated. And the stepwise intensification is also important. And keeping the regime simple and dosing flexible is again very, very important to keep to improve the timing. If we look at this, we have to identify. Now we know that we have 2 generations of the basal insulin. The first generation, that's insulin glargine 100 and the insulin detamir, and the second generation basal insulin, we know the glargine 300 and the insulin degludec. And it is important to understand the differences between the first and the second generation basal insulin analogs. It is again very, very important to highlight that as far as the efficacy is concerned, that is the ability to bring down the HbA1c, it remains the same with all the first generation as well as the second generation insulin. However, the newer analogs have longer and more stable PK and PD profiles. They have low variability with predictable and stable glycemic control beyond what we achieve with the older insulins. They have longer duration of action, more than 24-hour coverage, reduced glycemic variability due to more stable PK profile, and better injection time flexibility. At the same time, there is a lower risk of all-day hypoglycemia as well as the nocturnal hypoglycemia, and there is a greater improvement in treatment satisfaction, patient-related outcomes, and the quality of life. So if you see, just a second, sir. If you look at this slide where we are talking about the improved control over glucose variability, one of the study by the Yu et al. Compared the real world benefits of the glargine 300 versus glargine 100 in lowering nocturnal fluctuations in the blood glucose levels and the nocturnal hypoglycemia in people with type 2 diabetes. And the mean nocturnal glucose level was, however, similar, but there was a significant difference in the variability in mean nocturnal glucose levels, which is defined as standard deviation and the coefficient of variation, and the mean amplitude of the glucose excursion between nights. They were significantly lower when the glargine 300 was used in comparison to the glargine 100 for the duration of the treatment. And also, glargine 300 is comparable to glargine 100 in providing tight glycemic control, but it had a greater potential to reduce the frequency of nocturnal hypoglycemia. At the same time, its significantly lower glycemic excursion was observed during the last 4 hours of the 24-hour injection interval when it was compared to the glargine 100. And irrespective of the morning or the evening injection, mean 24-hour glucose curve for the glargine 300 groups was smoother than for the glargine 100 group, again indicating lower glycemic excursions. As we have seen that the HbA1c of 7.2 in 2 different patients may not be the same, and the path taken to achieve this HbA1c may be totally different. So improving glycemic variability can actually improve the outcomes in patient, as highlighted by Dr. Mangesh sir. Another study by Yamamoto et al. In type 1 diabetic patient, it investigated the difference in glycemic variability between glargine 100 and IDEC using CGM. And what the result the results of this study was that the mean amplitude of the glycemic excursion was significantly reduced with degludec, as was the area under the curve for daily blood glucose levels, and degludec confirmed reduced hypoglycemia and daily blood glucose variability in participants with type 1 diabetes as compared to the glargine 100. Another study by the Iga et al. In patients with type 1 diabetes found that the fasting interstitial glycemic variability on the CGM curves was significantly less with IDEC than glargine 100, and the authors of this study concluded that while the hypoglycemic episodes were similar with both IDEC and glargine 100, treatment with IDEC was associated with lower glycemic variability. we know their second generation basal insulin, Glargine 300, as well as insulin degludec, and they have been also compared with each other. And a study compared the PK and PD profile of Glargine 300 versus IDEC 100. And what they found is that IDEC demonstrated that an evenly distributed PK profile and better steady state PD profile with Glargine 300 in people with type 1 diabetes with once daily dosing regime of 0.4 unit per kg per day. However, another study reported that IDEC 200 had lower intraday variability and interday variability compared to Glargine 300. As we know, the BRIGHT study was the first head-to-head clinical trial which evaluated the efficacy and safety of Glargine 300 versus IDEC 100 in insulin-naive adults with type 2 diabetes who were inadequately controlled with OADs. And both the insulins provided similar glycemic control, but with relatively low and comparable hypoglycemia incidence and rates during the overall study period. Another study, that is the CONCLUDE trial, reported that incidence of overall symptomatic hypoglycemia was not significantly different when we compared Glargine 300 and IDEC 200, and the study could not meet its primary endpoint, so secondary endpoints were considered exploratory and not conclusive. And a small-scale study also used CGM for comparing the safety and efficacy of Glargine 300 and insulin degludec. So this was the results of the CONCLUDE trial, which we have already discussed. And again, one of the important key findings was that the mean percentage of TIR was similar with both the insulin types, but the percentage of time in hypoglycemia was significantly lower with the Glargine 300 when compared to the degludec, and the percentage of the time which was spent with nocturnal or severe hypoglycemia was also significantly lower with Glargine 300 with insulin degludec. So the study showed that during insulin degludec treatment, the mean percentage of the time with hypoglycemia, especially nocturnal hypoglycemia, significantly correlated negatively with albumin level, possibly as a result of the reversible binding of the insulin degludec to the albumin. So it is important to understand that although the use of CGM allows better assessment of the glycemic control, taking TIR into consideration, large-scale studies based on CGM to compare the safety and efficacy of the Glargine 300 IDEC are still lacking. And the InRange is again an ongoing multi-center phase 4 study that will collect CGM data over 20 days in adults with TM and DM receiving either Glargine 300 or IDEC 100. So what we get? What are the clinical insights on TIR recommendation which are available now based on the modality of treatment? Second generation insulin like insulin degludec and Glargine 300, they score better than insulin regimes in terms of increased duration of action, lesser glycemic variability, improved quality of life, reduction of the diabetes distress, better adherence, prevention of the cognitive dysfunction and long-term complications. And in practice, they perform they have lower hypoglycemia compared to first generation insulin. And TIR recommendation, we need to understand, they remain the same regardless of the modality of the treatment. It doesn't change with whether you use OHA or the insulin or the GLP-1, and the treatment should be directed at achieving the TIR, as we have seen earlier why it is important. And this can be achieved with basal insulins, especially the second generation basal insulins, though there are minor differences among them also, but we need to have more data to say something more conclusively. And the TIR target remains the same regardless of whether the patient was on any insulin or the OADs. So with this, I would like to conclude this presentation, and I would hand it over again back to Manoj sir for the presentation.
Thank you, Amit. And well, I think let's have everybody here into the. Yes, so we have. Great. So I think everybody's finished in time, and we have some time for our question and answers and discussion. Would invite questions again from all the faculty. Yes, can we have the spotlight on the gallery, or we already have it?
It's there already.
Okay. I don't know. I'm still continuing to see Amit and 3D. Okay. We had different talks, and I would again ask Dr. Anjali and organizers if there are questions from the delegates to post that to us. Let me start by asking Jyoti. Right. So Dr. Jyoti, there is some criticism of the entire time in range thing, and I'll give a practical example in asking. Now, there may be individuals who may be starting their day in the morning in the sugar range of 150. And you see their CGMs and you see that they are starting at 150s, and probably after each meal, you will see then them jumping from a baseline of 150 to 200, 210, and then it starts coming down. So if you see they're starting at 150s, 160s, staying there, there is a certain peak after a couple of meals. But when you look at their time in range, you get a time in range of about 75% within range, because you have kept your time in range standard as 70 to 180. So they're getting a 75% time in range, but their actual Hba1c is stuck around 7.8 or 8%. Now imagine this scenario. And there are a lot of those out there with who are starting the days at 150. So how, the other point here is that one feels that probably getting the time in range to more than 70% is much easier than having your Hba1c under 7%. Comments from Jyoti and all Mangesh and Amit. And
absolutely. There are 2 or 3 points. I will have quick answers to your question. Number one, all the CGM devices are not having the same accuracy. Number two, like what has happened with the glucose meters over the last 40 to 45 years, the CGMs are also advancing in their accuracy. And there are only 1 or 2 CGM devices which are approved by US FDA for non-adjuvant use. So non-adjuvant use means you can use it without the glucometer for either a calibration or for verification. So when you are using the devices currently available in India, please remember they are fairly very accurate, but you should be, even if in the absence of a calibration, the patient should be taught that they should be cross-checking with the glucometer, because sometimes there can be a difference of 20 or even 30 milligrams per deciliter or even more. And in the same subject, the difference will remain the same for 14 days. And the last point that we discussed, Dr. Manoj, as you have said in the introduction, it all depends upon the duration spent in hyperglycemia. So there is a level 1 hyperglycemia and level 2 hyperglycemia, and the time in range is picked up only if it is at least 15 minutes. So if the 200 or 240 is 30 minutes or 1 hour after the meal, and if it is very transient for 5 or 10 minutes, it disappears. It is not picked up in the TIR. So that is okay. And of course, if it is relevant enough, then it will be shown in the TIR. And that is exactly the reason why, Manoj, you also said in the beginning, you should be treating TIR separately and you should be treating A1C separately. So if the postprandial glucose excursions are significant enough, that is an indication that you have to change and you have to modify the therapy.
thanks, Jyoti. Yeah, sorry, Anjali.
Yeah. May I have a question over this, sir? Sir, I mean, it may be too early to say anything like that, but I think HbA1c is a marker of glycosylation of the hemoglobin. It may not always correlate with the glucose level in the blood, because there are many processes between the blood glucose in the blood being, the glucose level in the blood being high and the hemoglobin getting glycosylated, because I think there are different people who have different types of glycosylation. What do you think, sir?
Anjali,
what would correlate more with complication, glycosylation or the level of glucose?
So I think so far we've had, because we were not looking at the glucose levels as closely as we are doing now through CGMs in time in range, I personally feel that the link with TIR with complications is going to be much stronger evidence. But prior to this, as HbA1c was the only verified metric, we use that. Today, we know that HbA1c in the normal range also has a huge variation between Asians and Black Americans and Africans and Caucasians. But that 7% has been more generalized. But today, we still have that strongest link. Probably things will change as we move on, which actually gets us to the next question. And I can see Dr. Shashank has also joined in and put comments from him, Mangesh and Amit to this next question. And the doctors asked us, and it makes sense that for Indian patients, should the time in range be from 70 to 180 really? Or you think maybe moving it up to 80 to avoid more time below range and hypoglycemia, and probably the upper one at 160 may give us more a better insight if we change it from 80 to 160, especially the lower one. Mangesh?
Yeah, so I would probably answer this in a couple of ways. First and foremost is these are all the developing areas where we are still working on it, and there are no specific I would say data which have been really as Hba1c has gotten hard outcome data which we have.
Mangesh, quick answers. The moment you see
Yeah.
Nita on screen, that means, you know, you guys have to shut up and get
so
out.
probably I think we need to stick currently to the recommendations at present. We need to still generate the data.
For global parity, stick to the current data.
Yes.
Because you have a point, two things. We need to validate it in Indian circumstance. And you and Jyoti should take a lead and do that.
Yes.
Because, you know, in the Indian circumstance, actually, the Indian true fasting is 66, which a study was done at KM Hospital by our diabetology students almost 20 years back. And it is published also. And that, you know, the normal Indian fasting sugar is 55 to 65. So if it is 55 to 65 as normal Indian sugar, then we need to really work it and develop an Indian norm. But I think you and Jyoti Dev can have a CGM norm or an interstitial fluid glucose norm.
Yes.
That is a work in progress.
I think that's a great point by Shashank, because we've been doing CGM in a lot of pre-diabetics and even normal glucose tolerant individuals because they wanted to study. And it's not surprising to see the sugars in the 60 to 70 for non-diabetic individuals without any symptoms. So absolutely right that, you know, the lower normal, and this is not on the first and the last day, which may give us errors, but actually readings being in that range. I think we've had a wonderful session on time in range. I can see that the time's up. Hopefully this session has been an awareness creating session for many physicians attending today to understand the emerging concept of time in range better, and appeal that let's understand this. Let's include this metric as far as possible in our regular clinical applications, because this will be one metric which may improve the lives of people with diabetes, and importantly, hand the control to them to understand this better and work towards improving the overall time in range and avoiding hypoglycemia. Most importantly, avoiding the time below range. Thank you so much for having all of us here. I hand it back to the organizers.
Thank you.
Thank you
Nita.
so much.
Thank you, everybody.
Thank you.
Yeah.
Thank you very much, Manoj and team. Dr. Mangesh Devaskar, Dr. Jyoti Dev and Amit, thank you so much. It was a wonderful session. And we will now move on to the next session that we have on our agenda. And it's an entire afternoon of drug reviews and therapeutics. And for this, to start off and kick the proceedings along, we have our very first speaker, none other than Dr. Shashank Joshi, who is now going to take up the first talk in the drug reviews and therapeutics session. And Dr. Shashank is going to talk to us about reviewing the evidence, glycemic control and weight loss with dapagliflozin. And absolutely, I'm sure that Dr. Shashank Joshi needs no introduction at all. And he is a very good friend, excellent speaker, orator, great academician, and his bio data will run into several pages. So I won't go into the details because everyone is aware. And I am now going to ask Shashank to please proceed with his talk.
Thank you, Nita. Thank you, Sanjay, Nita, Anjali, everybody, for keeping this. You will have to allow me to share the screen, please. Hello?
Yes, it's done.
I'm not able to share the screen. You will have to.
Are you enabled now?
Yeah. Can you see the slides?
Yes, I can.
Yes. So this is a talk. I have duality and conflict of interest for this talk because it's with micro labs, and I also have a duality and conflict because all the four actually SGLT2 inhibitor companies have some relationship with me either as a speaker bureau, advisor, or research trials. So thank you, Dr. Agarwal, Dr. Deshpande, Dr. Sarda, Dr. Bhatt. We are going to review evidence on glycemic control and weight loss with dapagliflozin. And it is going to be in context because, you know, Dapa now has become generic as far as India is concerned. So we all know this very well. Diabesity is the predominant driver of type 2 diabetes in India. And we know its complications like cerebrovascular disease, cardiovascular disease, micro and macrovascular events, renal complications, dementia, cancer, and even eye disorders are well known. We also know that in the Indian scenario, generalized obesity is around 58% when we use the Indian cut points, and combined obesity of diabetes and obesity is around 53.4%, and abdominal obesity is around 81%. We also know that clearly the risk with the BMI going up, just like Hba1c going up, the risk of prediabetes and diabetes goes up. And the lifetime risk of progression of prediabetes to type 2 diabetes is increased by BMR data and waist circumference data. The Rotterdam study showed us very early, and we know that the age of onset of prediabetes was around 10 years later for adults with normal weight strata compared to the obesity strata. Now, we as an ethnic group, Asian Indians, are more at risk both for diabetes and obesity. And probably the Asian adults have a 5-year risk of progression to type 2 diabetes within years versus Caucasian. So we have a malignant transformation from pre-diabetes to diabetes. And the prime driver in that is probably obesity. Because we know obesity drives inflammation, which is chronic, in the adipose tissue, liver, hypothalamus, pancreatic islets. And eventually it leads to systemic insulin resistance and beta cell dysfunction. And that's really the core. We also know that we need to do a tighter glycemic control in people with type 2 diabetes and obesity, because we know the diabetes patients, the prevalence is high and most of them have a very poor diabetic or a glucose control. And obesity is a determinant of poor glycemic control or metabolic control. So glycemic control in obese patients with type 2 diabetes is very key. And in order to prevent microvascular complications, because it significantly affects quality of life as well as outcomes. So currently we have a lot of challenges with weight gain during anti-diabetes therapy. We know considerable amount of anti-hyperglycemia therapies have considerable effects on patients' weight, and careful consideration for weight loss therapy in people with diabetes and obesity is now the standard of care. For example, glitazone, sulfonylureas, glycides, insulins all cause weight gain. We know gliptins, fixed ratio insulin, GLP-1s, and various other therapies are weight neutral. And it's only that the ones which promote weight loss or maybe weight neutral are metformin, SGLT2 inhibitors, GLP-1 receptor agents, alpha glucosidase inhibitors, and amylin myelomatics, in which top on the pecking order is SGLT2 inhibitors. In fact, it's the era of SGLT2 inhibitors. And clearly we know that an OHA which improves glycemic control and reduces weight is clearly the need of the hour. So SGLT2 inhibitors have arrived, and their role in weight loss is dual. They essentially have an impact on body weight in diabesity through two mechanisms. One is by increasing urinary glucose excretion, they cause caloric loss and weight loss and reduction of fat mass. And second is by reducing the insulin to glucagon ratio, they increase lipolysis and they actually melt fat and they cause weight loss and reduction in fat mass. So clearly, and without affecting the lean body mass. So this is very, very significant that clearly they shave off the fat through the lipolytic mechanism by reducing the insulin to glucagon ratio, and by causing simple glucosuria and calorigenesis, they are able to lose weight. So Asian type 2 diabetic patients with abdominal obesity, the clinical recommendations are very clear cut. And it is recommended to promote weight loss, to reduce visceral adiposity in Asian patients with type 2 diabetes and obesity. So it's a recommendation from Asia to promote weight loss. We can use SGLT2 inhibitors. In fact, 2/3 of the SGLT2 inhibitor induced weight loss is attributable to reduction of body fat mass. And it also reduces waist circumference, ectopic fat deposition in non-adipose tissue, improves adipose tissue function, quality of life, and patient reported satisfaction. Clearly, some time back, this was an evidence-based consensus position statement, which was come out with several authors. And you can clearly see that weight reduction due to loss of fat mass is primarily from the abdomen rather than lean mass. It's not only the weight loss and the glucose control, but it's durable, it's sustainable. So both the glycemic control, body weight, and blood pressure reduction with CV benefits and renal protection is sustained without any risk of hypoglycemia. And there is a persistent calorie loss. So clearly this is sustained, durable glucose control, blood pressure control, cardio-renal control, cardiometabolic control, and that of course Gagan Priya will talk on it. But my predominant focus today is on weight loss and reduction of body weight, more visceral fat mass loss than substitute fat, reduction in insulin resistance, and improvement of beta cell function is what SGLT2 inhibitors do. So in the Indian patients, we know they have more abdominal obesity and visceral fat at any given BMI, and SGLT2 inhibitors by evidence base in India reduce that. The higher waist circumference and higher waist to hip ratio is reduced. The lower adipokine and higher plasma leptin levels are reversed. The lower rate of glucose disposal is modulated and increased, and the beta cell function and insulin resistance is improved. Also remember, SGLT2 inhibitors in combination therapy have a huge impact. For example, SGLT2 inhibitors combined with drugs which reduce food intake like GLP-1 receptor agents on energy intake and energy expenditure and their compensatory effects. Clearly, you can see here that they can have a greater weight loss in two ways. They increase food intake by evoking energy loss during SGLT2 inhibitors, and that can be partly prevented by appetite reducing therapy. So clearly you can see the equations on both the sides of the curve. The SGLT2 inhibitors will increase the EE via glucosuria, and the food intake inhibitor like a GLP-1 receptor agent will decrease EE via cellular metabolism. And the combination of the two is clearly synergistic. And the reduced cellular energy expenditure occurring after weight loss achieved by the GLP-1 receptor agent is balanced by the urinary caloric loss secondary to glycosuria. So these complementary mechanisms of actions again make it very attractive for weight loss. So what do the guidelines say with diabetes and obesity? Clearly, if you see the ADA 2021, obesity management can delay progression from pre-diabetes to diabetes and is highly beneficial. In fact, off-label, many of us in pre-diabetes with obesity are using the SGLT2 inhibitors after it has become generic. It is modest and sustained weight loss which improve glucose control and reduce the need of glucose-lowering medications. And this is the evidence based on that. And it is pretty compelling as the BMI goes up. Clearly, beyond diet, physical activity, behavioral therapy, when choosing a glucose-lowering medication, one must compare the impact of that medication on the body weight. And after metformin, SGLT2 inhibitors is clearly there. Of course, there are other agents also, but they are minimalistic in that recognition. If you look at the American College of Clinical Oncology ACE recommendations, they again say it is individualized therapy, try to reduce body weight by 5 to 10%, and probably SGLT2 inhibitors have a glucose-uric effect with reduced A1C, weight, and systolic blood pressure. So clearly they are there. The RSSJ ESI therapeutic whale was made in 2020 when the finance F feature SGLT2 inhibitors were not generic. And now we know that it is generic. So obviously, I think it's the only anti-diabetic agent with this feature with cardiorenal protection, weight loss, and is economical as well. Obviously, the efficacy is something which we need to establish. Is there evidence base for Dapa with established type 2 diabetes for efficacy on weight loss? Clearly, you can see that the clinical considerations are clear-cut. It lowers glucose independent of insulin action. It has a sustained effective glycemic control, reduces body weight, low risk of hypoglycemia, very well tolerated as monotherapy or as an add-on, reduces blood pressure, rate of cardiovascular death and heart failure, hospitalization, and progression to renal disease. This is data whether you add Dapa on monotherapy, add on to metformin, SU, MET and SU, gliptin with or without metformin or insulin. It is consistent. If your A1C is 8 to 9%, 0.5 to 1% drop in A1C in Dapa has been observed consistently. So the clinical trial data and the real world data, both are consistent. Both the data, the RCT data and the real world data, shows that A1C drops by around 0.8, 0.9 or 1%, as well as the weight loss is also achieved. So dapagliflozin achieves a comparable reduction on A1C and weight in real world practice as seen in randomized clinical trials, and we have seen this in clinical practice. And it also has a very, very important impact on energy metabolism, which I was talking about. This is a RCT which was done, and you can see here in this RCT, clearly, Go et al. Showed body weight was significantly reduced by dapagliflozin versus placebo. And in 5 weeks itself, within 5 weeks, there were metabolic adjustments mimicking caloric restriction. Fat oxidation was increased. Hepatic and adipose tissue insulin sensitivity was improved. And 24/7 energy metabolism was improved. So clearly you can see that in real world practice, it achieves quick A1C control. 80% have more than 1% A1C reduction, and 65% show both an A1C drop and a weight loss. Clearly, this data is consistent. It maintains glycemic control and weight loss over a period of time. That's also very crucial, that it must last. It should not rebound back, and that is very consistently seen. And the data is consistent in Indian patients also. Dr. Vijay Vishwanathan's study I'm quoting here, where he has shown with Dapa, clearly it is a sustained effect not only on A1C, also on the BMI, body weight, and waist hip circumference. So clearly now we have data from that study, which was an Indian pan-India study where Dapa was well tolerated. A1C and body weight came down in 6 months, and it achieved a significant weight loss. And various other replicative studies have also shown that it not only causes weight loss, but if you study the body muscle mass and muscle fat content, it is only the fat mass which is lost without reducing muscle mass. So this is a very, very crucial study by Sugiyama et al. From Japan, where they studied, because the big fear is that people suddenly will say that we have lost a lot of weight, we lose muscle mass, but muscle mass is preserved and only fat mass is. What is unique about this molecule is that it also inhibits the hepatocyte death, because clearly it induces the reversal of NASH. You can see our SGLT2 inhibitors reduce inflammation, tag accumulation, and tunnel positive apoptotic cells in the hepatocytes. They reduce the insulin resistance in the liver, reduce the de novo lipogenesis in the liver, and increase the fatty acid oxidation in the liver. They reduce the inflammation, the reactive oxygen stress, as well as response, and hepatocyte death capsase 3 is reduced. So clear-cut down regulation is seen, and fatty liver, it chops off the fat. This was a RCT with Dapa, where hepatic and visceral fat was clearly reduced in a 12-week study, and this is some compelling data which is there. Also, when you add it with insulin with OADs, usually it is very well tolerated, body weight is reduced, and many a times we are able to chop off the insulin as well. Also, this is a meta-analysis where you compare 2.5, 5, 10 milligram and 20 milligram of Dapa. You can see the weight loss reduction is consistent. So you can see it's all on the left side favoring dapagliflozin, and clearly you can see that weight loss reduction is dose dependent. So higher the dose, the better is the dose reduction, and body weight is significantly reduced in people with different doses of SGLT2 inhibitors, and it is statistically significant dose dependent. Clearly you can see that weight reduction is significant, it is compelling, and it is impressive. So the key insights which we learned today is that SGLT2 inhibitors on body weight is an important component for obese people with type 2 diabetes with consistent weight loss, which is vital for effective management. And that is why SGLT2 inhibitors have become universal agents. I call them versatile agents and universal agents now. They probably might replace metformin. The data is coming up so much that the cardiologists and nephrologists have already taken them away. And I'm certain that in times to come, the obesity experts will also take them away, because they are originally diabetes agents. But the data is so overwhelming that particularly Asian patients with type 2 diabetes, whether in combination or in monotherapy, they promote weight loss. Dapa maintains glucose and weight loss, which is sustained over a year or two. And early use of Dapa enables not only better glycemic control with weight loss and can become a standard of care in routine practice. Thank you for a patient hearing. Thank you for a patient hearing.
Thank you so much, Shashank, for excellent deliberations.
Thank you so much, Shashank, for excellent.
1 second. Yeah, my question to you, Shashank, at this point is, since we're talking about weight loss with dapagliflozin, if we had to actually use an agent for weight loss with good glycemic control, obviously SGLT2 inhibitors are the choice nowadays. But do you see any difference between the weight loss effect of different SGLT2 inhibitors?
So that's a good question, Nita. Is it a class effect or is there a differential effect of different agents?
Yes.
So currently, if you ask me overall, if you look at the SGLT2 inhibitor ability or capacity, you have Cana, which is the broad spectrum, then Dapa, which is intermediate spectrum, Hba, which is restrictive spectrum, and Remo, which is again a broad spectrum. So from the SGLT2 inhibition perspective, it doesn't impact weight loss so much. If you ask me, more or less, we will expect it to be similar for all. The data is best generated in terms of liver fat, visceral fat, RCT data, Asian data with Dapa. So when it comes to evidence base, it is most documented with Dapa, but I would not be surprised if it also is replicated by other agents. See, each SGLT2 inhibitor has its own molecular nature, and each one of them will have some impact. Now, one thing is sure that Cana 300 mg was supposed to start a study called CAN-FEN study for obesity. And they had to abandon the study because, Cana got associated with amputations. And that is why they had to take up the study. Dr. Panikar and myself, a couple of years back in JAPI, published our own data from Lilavati on various SGLT2 inhibitors. We found that by and large weight loss was similar, but Cana 300 may have a little more weight loss, was what was observed. But currently, as I said, Cana has its own challenges with adverse events. And Dapa is probably having much better data on kidney and heart. And that is why probably the preference as a universal agent on weight impact is better. Also, the energy metabolism studies, Nita, which I alluded to, have not been replicated with other SGLT2 inhibitors. With Cana 300, there were 2 trials which were attempted. Both the trials showed weight loss, but no energy metabolism study has been documented. Fatty acid oxidation studies are universal for all the 5 SGLT2 inhibitors, including ertugliflozin and remogliflozin. But those are early phase 2 trials. So from a data standpoint, Dapa has an advantage. Dapa has been the agent now, this is a SGLT2 inhibitor year, if you ask me. Next year might be a semaglutide year. So, and Dapa has become generic. It is easily available and accessible to most of our patients.
Right. There is one question from the audience. Dr. Sunil Mewada wants to know, can Dapa be given in non-diabetics for weight loss?
So off-label, whether it should be given or not in the research trial, it can be given. I have used it off-label in pre-diabetics. But in absence, normal glucose, I may not use it. But our cardiology colleagues and nephrology colleagues, now it's actually approved to use it for other indications. So I am certain that SGLT2 inhibitors will find a space in the obesity space as well. They will get very close competition, and Neeta will agree with me, from oral semaglutide. Right. Only thing is, oral semaglutide does not have CV outcome. The SOUL study is a soul searching study. If that SOUL study comes positive, then they will be in neck to neck with an agent like Dapa. In absence of the SOUL study, the current agent of choice probably, which is affordable, accessible, available, is probably Dapa. It's worth trying, but I would not say, because you also remember every agent which works has adverse events. So it can cause genital mycotic infections, it can cause urinary infections, it can lead a patient into euglycemic diabetic ketoacidosis. A lot of our patients do these fat diets like keto diets. So it can also be deleterious at times. So you need to be a little cautious and careful when you use some of these agents.
Right. There's one question that I would like to ask you, Shashank, and we've all seen in practice that, and in the clinical trials, that it's about 3 kg weight loss is what we expect when we start, and it is pretty much durable. But then there is a subset of patients who lose far more. And we have also documented that. So can you explain why some people lose so much more weight? What could be the determinant so that it's easier for us to focus on those patients for weight loss?
So Neeta, this was studied by Cgm et al. And this was studied in that study. I would send you the full text of the paper. 2 things.